The purpose of today's session is to look at the healthcare infrastructure in some large cities across the country and to learn about when the healthcare infrastructure changes, such as a hospital closure or a new hospital being built. What are the potential impacts on the population and that the facility would serve, and what are the causes of the event, what led to the event itself. However, because Walter's the situation in Philadelphia is just a little more content of interesting events, one of which is fairly quite recent. I'll have Walter go last. And I know he's extremely patient now that he's retired and all that. Anyway, and he's so I would like that. And however, our two new guests who have not been part of the internship in previous years, I think we can lead off with them, and we'll have Susan Rogers. We'll be talking about the situation in Chicago, where she's worked and lived for maybe her entire life, but we'll get into her situation just a little later. But we'll start off with the city of Atlanta, and I have a brief bio on Toby, which I'll read, and I haven't gotten one on Belinda yet, so we're gonna discuss these in a little more depth because to me it's of interest to know the people we're working with a little better. We'll start out with Toby Terwilliger. He is our first guest, a board certified physician in both internal medicine and pediatrics, and currently practicing at Grady Memorial Hospital in Atlanta. He earned his undergrad degree at SUNY Geneseo and then his medical degree at NYU School of Medicine, and did his internal medicine peds combined residency at Rutgers in New Jersey. And he's been an advocate for expanding access to care and achieving universal health care, and is co-chair of the Georgians for Universal Health Program and a member of the board of directors of Physicians for National Health Program. And he also co-leads the Emory at Grady Health Equity and Advocacy course, helping to train, would that be medical students? Maybe he can tell us about that, and also about Georgians for a Universal Health Program. So Toby, tell us a little bit about that.
Yeah, of course. And thank you, Marvin, for having me. It's good to see everyone. And Anna, it's good to see you. It's good to have some Atlanta representation on the call. So yeah, my name is Toby Terwilliger. I am a hospitalist at Grady Memorial Hospital. And specifically, Marvin, in regards to the two questions that you asked. So Georgians for Universal Health Program is just what we call our state chapter of PNHP. So that is essentially the Georgia chapter of PNHP. We had decided to kind of rebrand ourselves just to try to engage with a wider audience, including non-physician members, just to see if we could grow our membership a little bit more and become a little bit more accessible to Georgians who may not be as familiar with what a national health program means. In terms of the advocacy curriculum, so 3 years ago, Emory started a health equity advocacy course that focused on actually faculty and introducing faculty to different concepts in advocacy. I actually took the course as a participant in the initial cohort 3 years ago, and then the director of the course at the time is now in DC on a Robert Wood Johnson fellowship. So she had asked me if I would be willing to direct the course, and so I wound up co-directing it this past year, and we held 7 sessions for our faculty members from October through March, introducing them to different types of advocacy, introducing them to individuals within the Atlanta community who are engaged in advocacy, and helping them to get started on some different advocacy projects.
Thank you. I appreciate that. I want to pick up on something you said though, because something for everyone to think about. Okay, so in Vermont, a very small state where I live, only 600,000 people, it probably wouldn't constitute a fifth of Atlanta, if even that. We have at least four, and probably you could say five different organizations in their, a non-populous state who are advocating for Medicare for all or single payer healthcare. They all have different names. And I think a decision you have to make wherever you settle is, do you want a broad organization that's going to try to bring everybody in, or do you want to have a Physicians for National Health Program chapter that would, we do have members who are not physicians in nationally and in Vermont, but it's a little harder to attract people, especially people who value their independence, like nurse practitioners who may be very progressive. They may not be want to be part of an organization called Physicians for National Health Program. So there's various strategies. In the case of Atlanta, it sounds like you've just changed the name to make it inclusive right away, right off the bat. That's a good strategy. Another possibility, if you still want to have Physicians for National Health Program, so that you can say, oh, we're a physicians organization, we advocate for this, and that looks good too. So I think this is a real dilemma that people have to think about when they're organizing and forming different groupings. So that was an interesting angle. And Belinda McIntosh, I don't have your bio, but that's perfectly okay because we're real informal here with this session. And the students should definitely feel free to interrupt anytime they like because of that. Anyway, Belinda, tell us about your background and what brought you to become an active, as well as your training, that kind of thing.
Sure, sure. And I'm sorry, Marvin. After we got off the call last night, I completely forgot to send you my bio, but I'm
No
a
worries.
I'm sort of a lot like Toby. I am a co-chair for the Georgia chapter for PNHP. I live here in Atlanta and I work in the Grady Health System, which is the large safety net hospital. I work in the outpatient behavioral health clinic. That's part of Grady. I'm a psychiatrist, and I'm also on the national board for PNHP. And at Emory, so I'm an Emory faculty member who works at Grady. That's where I do 100% of my clinical work. And I also do some teaching in the School of Medicine. I did my undergraduate degree at Harvard. I went to medical school at Duke, and then I transferred to Emory. And then I finished medical school at Emory and stayed for my psychiatry residency there. And so I've been in Atlanta since 2000, but I was born in Jamaica. I grew up in New York and then Miami. So I've lived in a lot of places. And then as a psychiatrist, I've worked in a lot of different clinical settings, large outpatient community health hospital, private residential treatment facility for people with severe mental illnesses, college mental health, university mental health at Georgia Tech and at Emory, the Atlanta VA, which is one of the largest and fastest growing VAs in the nation, Veterans Affairs hospitals in the nation. And I ran a private practice for 10 years before coming back to Emory for a second time. So my journey with PNHP and with advocacy really kind of began with my roots growing up in a family that was Jamaican and fairly energized around, at that time, growing up in the 80s, fighting against the apartheid system in South Africa was something that people in Jamaica were really on board with. And so I just grew up in a household that was really attuned to politics and policy. And so I was introduced to PNHP when I was a resident by one of my attendings, who is now one of my dear friends, and Toby knows her well. She's also on the steering committee for PNHP. Her name is Karen Hotchman, and she's been a longtime member of PNHP. But I wasn't super active in PNHP during residency, and it wasn't until about 2018 when I became more involved. And Toby and I will share a little bit of, the sorts of things that we did in the years after that, 21, 22, as our chapter became much more activated than it had been for some years.
What prompted it that year, if you don't mind asking?
Well, you know, interestingly, our chapter needed sort of a bit of a rejuvenation or rebirth. We have this fantastic chapter founder who's still a very active member of our chapter, Henry Kahn. He received a lifetime achievement award from PNHP a few years back. He's just, you know, one of the original founding members of our chapter. And he sort of ran everything, kept his finger on the pulse, kept us all updated about what was going on in the system of healthcare and what was going on in Georgia and what was affecting patient care. He's a primary care physician by career, and he's also worked at the CDC, and he's retired. And there was a point where it became clear to Henry that he can't continue to be the only person who's really leading our chapter. And so at that point, he reached out to Karen and another one of our longtime members, Rita, gosh, now I'm blanking on Rita's last name. Toby, help me out.
Valenti.
Rita Valenti, obviously. Thank you. So Rita Valenti is a longtime member, and she's is a nurse, and she has been very active in the National Nurses United, and she's been a very integral part of our chapter. She also served on the state in the state House of Representatives for Georgia. So this very small group got together and said, we need more people. And they reached out to me and a few others back then and said, let's form a steering committee so that we can all be in tune with what's going on. All of this isn't on Henry alone. And that's how our chapter began to grow again. We had about maybe 8 or 9 or 10, maybe 8 or 9 members of our steering committee then. And some were students, some were faculty at the university, like at Emory, some were in practice. And we, you know, got together, formed the steering committee, created a very basic strategic plan for ourselves because we wanted to become more active and involved. And it turns out that, you know, in 2021 and 22, a lot was going on in Georgia. We were fighting against our governorship and our state house in their refusal to expand Medicaid. We were watching, I think something like 10 rural hospitals closed in Georgia by 2022, which is when a very big downtown hospital was closed, which we'll talk about on a little bit later. And so there was a lot of reasons for us to become more engaged and have more people doing the outreach. And so, you know, we pulled this group together. We started to you know, attend rallies. We decided to support the Medicare for All resolution, the National Medicare for All Act at that version at that time, 21-22, and we made a petition, a resolution to Atlanta City Hall. That was the year I became most activated in getting that resolution passed, and that is the year that Toby also moved down from New York, and we reached out to him, and he joined our chapter, and he's become such an effective leader for us. So we just it kind of organically happened because it needed to, and we're still evolving in that way, trying to grow our steering committee.
Thank you. I appreciate that. And I just want to point out that you guys did a really clever thing, which everyone should know about, which is that if you're in an organization and you're trying to recruit more people to become active, you actually find someone, immediately appoint them to be the head or into a high position where they're actually, you know, have some responsibility and not just like the added person that you don't pay attention to. Get them involved right away. Give them a nice title. So Toby, congratulations on your title. I'm sure you deserve it. Anyway, I would like to, however, get to talking about Atlanta. So if you two could describe the events in Atlanta, that would be great. And if you know about the rural situation, we can get more to that later. But let's start out with Atlanta. What happened in the year 2022?
So I'll just very briefly, because I've said a lot already, and I'll turn it over to you, Toby. So in 2022, we learned that this private for-profit healthcare entity that had purchased there were 2 safety net hospitals in downtown Atlanta, and they were both level 1 trauma centers in downtown Atlanta Medical Center and Grady. And Atlanta Medical Center was previously known as Georgia Baptist, but it got bought out by one for-profit hospital group, and then that one got bought out by another one. And the idea is if you have a hospital whose reimbursements are coming from insurance companies, they're more likely to be able to turn a profit. But if you have a hospital where the patient base who are served by that hospital are either uninsured or on Medicaid primarily, it's much harder to turn a profit on a hospital like that. And yet these big private entities came in, partly because they get subsidies to be able to provide some care to patients who are indigent. But in the end, it wasn't profitable to these companies. And so they announced the closure. Atlanta Wellstar is the hospital chain that bought up Atlanta Medical Center and rebranded it, and then announced that it was closing because they didn't have the money to keep it open. It was losing too much money. And so everyone in healthcare was upset by this. The community was upset by this. Remember now, hospitals are also affiliated with outpatient clinics. And so people come there to get care for an emergency. They also come there to get their routine care. And as you know, a lot of people rely on emergency rooms for routine care as well. So the announcement of the closure of AMC was sort of a crisis point for our city, for the other hospital, Grady, that serves indigent patients. And so PNHP just sort of got on the horn about that. We wrote op-eds about that. We held a rally about that. I'm going to turn it over to Toby to say more about what we did.
Yeah, thanks, Belinda. So I think that's a really great summary of kind of like the environment that we found ourselves in back in 2022. And what we found was that the community was very outraged by this, and it wasn't just healthcare providers. And so we wound up getting into contact with a lot of other community organizations that all had kind of intersecting missions, and some of them specifically were interested in healthcare, but there were others that were kind of interested in like decarceration and homelessness, and just a lot of these other intersecting issues that we all know are really part and parcel of healthcare, right? They dictate a lot of a community's health, as well as kind of what we do and what hospitals do. So we were able to kind of build or bring together this coalition. And this coincided also with the PNHP national meeting being in Atlanta. So it's kind of this like perfect storm of like, there's a lot of community level grassroots organization going around against this hospital closure. And then PNHP brought all of its members into Atlanta around the same time. And we were able to hold this fairly large. I think we had 120 some odd people, both from the community and from PNHP. We marched about a half a mile, and we stood outside of the Atlanta Medical Center, or Wellstar, where this hospital closure was, and had some really powerful speeches from physicians, from community members, from patients, tying together the failure of our state to expand Medicaid with the decision of this for-profit, I mean, technically not for-profit, but private hospital system that closed and left the community more or less abandoned. And again, we got a lot of press coverage. We published some op-eds about it. We had a bunch of students who wrote op-eds and papers throughout the state. So it was something that really was a driving force for our chapter. We were able to really kind of mobilize our members very well, but also I think built a lot of important relationships with other organizations within related spaces.
So you were able to get involved in a fairly broad coalition. And I would have to think that one advantage is that you could educate the other members of the coalition about what you know a lot about, which is universal health care. Do you think that that's a useful strategy other people can also take advantage of?
I think so. I think that there are so many injustices in our country, right? There are so many causes that people want to get involved in. And I do think that healthcare ties so closely into so many of them that I feel like universal healthcare is something that can unify a very broad coalition of people. And so, I mean, we saw like New Georgia Project was one of our big kind of co-sponsors of this event. They I think at their mission is like civic engagement, but they have a whole bunch of different kind of like subsections that get involved in different things. And one of them is focusing on like the health of communities. And so thinking about how we can kind of relate to that group, with the idea of, every single American should have access to affordable, high quality healthcare. That's something that resonates with that group, and I think with most other of these kind of like progressive organizing groups. So I certainly think that universal healthcare is a really strong kind of coalition building issue.
Any comments on that, Belinda?
Yeah, absolutely. And I think that as we've moved forward, I mean, a lot of things really aligned. I mean, literally, we brought the steering committee together. We passed a resolution at City Hall. And the day that we passed a resolution at City Hall, we also had a rally at Grady on the failure of the governor and the state house to expand Medicaid. And we're getting the news that Atlanta Medical Center was closing. And then the PNHP annual meeting was going to be held in Atlanta. And we just strung all of these things together and used everyone not only as an organizing tool, but also as a recruitment strategy to re-engage members of our chapter who had lapsed and weren't participating. So we also, right, Toby, we were planning a social event to just sort of bring people back out. We planned some Zoom meetings, and we even invited one of the great resources in PNHP are all of the folks who are on the board, many of them who've been involved in the organization for years, and having them come and be our guest speaker on a Zoom call, and have an educational opportunity for our chapter members to get people who may have been disengaged a bit more up to date on what's going on in the organization. And so another arm of what we've been doing is we made more connections with labor groups as well. And so I do think what's hard for me is keeping track and keeping in contact with all of the different coalition partners. And that's where I'm really grateful for Toby's leadership and the way that Toby has been able to engage students in the process of growing our chapter and doing the work and writing the op-eds and talking to people in their communities, because the Georgians for Universal Health program has historically been very Atlanta centric, but we know that the problems in Georgia are really severe in the rural areas. And so we're trying to branch out more and do more in the outlying areas and not just focus so much on Metro Atlanta, but indeed things happening in Metro Atlanta really helped us to, so you can build on that even if your chapter is really concentrated in one place. If you get a lot going, you can use that to engage people across your state or your region.
I guess before we get back to the urban situation, just to turn the attention to, you have hospitals in Georgia, rural hospitals that are in financial trouble, and some may close, maybe some already have. And I'm just wondering if in your efforts to reach out, have you found any interest even in the hospital leadership? Like, we now kind of take for granted that an organization like Wellstar, they're not going to support single payer reform. They're in a sense the opposition. They're making money off the healthcare system. Even if they're formally not for profit, their CEO is probably getting, salary and well into the six figures, or anyway. But the situation in rural hospitals is very different. We have a hospital CEO who was part of our internship for several years. Seems to be too busy this year, but describing his hospital's 18 months of Chapter 11 bankruptcy. And he's participated now for 5 or 6 years, and he's now become a single payer supporter. He didn't even know about it until I approached him to be part of this internship. and he realized that that what's going on in the US is not a reasonable way to organize a healthcare system. If you want to have functioning rural hospitals, you have to fund them, and so I'm just wondering if you reached out to the leadership of some of these rural hospitals and found any receptiveness.
Yeah, so that's a really great question. And we have actually been very fortunate. In Atlanta, there is an individual named Mark Craig, who I think would be a great person also to speak to this group. But he actually runs a nonprofit organization called Write Off Warrior, in which he helps rural hospitals deal with insurance companies essentially. That there's a lot more nuance to it, and he's like has a financial background. I can't explain exactly everything that they do, but in his work he has gotten to know the financial structure of rural hospitals really well, and has gotten to know rural hospital CEOs very well. He published an op-ed maybe 2 years ago about Medicare Advantage and how Medicare Advantage was harming rural hospitals. And just so everyone kind of knows, Medicare Advantage is like privatized Medicare. It's run by private insurance companies, tends to reimburse hospitals at a much lower rate than Medicare does, and also has a lot of denials, prior authorizations, other things that create headaches for providers, patients, and particularly for the bottom line for hospitals. So in his work, really focusing on rural hospital finances, he has been able to bring in a bunch of rural hospital CEOs that are kind of universally united against Medicare Advantage companies. Um, Similarly, they are harmed by the lack of Medicaid expansion. And so those are two issues that our chapter of PNHP feels strongly about. Georgia needs to expand Medicaid, and Medicare Advantage is harming our healthcare system. And so we have been able to find common ground on those issues. And so I've been on meetings with hospital CEOs. We have not Mark has explicitly spoken to them about single payer, and I think Georgia is politically in a place where I'm not sure that they're going to come out and support single payer at the moment, because they have so many other issues that they feel like they need to kind of politically gain ground on first. But I do think that there are receptive ears there, because they see the issues of like these corporate health insurers and how predatory they can be towards the rural hospitals. So Martin, I think that is a like you got it spot on. Like rural hospitals should be our allies in this fight, because they are being harmed by our healthcare system just as much, if not more, than just about anybody.
Okay, I'm going to sidetrack one more time because of something you said. Um, this idea, so okay, so you saw an op-ed piece or piece in the newspaper. Maybe you didn't know the person, but it's such a good piece talking about dysfunction in the healthcare system. So instead of saying, "Oh, that was good," and going on to the next item in your day, you could say, "I'm going to get in touch with this person and invite him to join Georgia for whatever this organization's called. I'm going to reach out to this person. It's obviously an intelligent person if they put together an op-ed piece and you agree with their politics and their positions. So that's a way to reach out and gain new members who have already had their own self-initiated activism of a sort to write an op-ed piece. Anyway, so nice going with that one. My compliments. But anyway, during this internship, we've started to study healthcare systems in other nations. And like they have organization of a hospital sector in most of the countries we're looking at, so that an appropriate sized community will have a hospital. A tiny community probably wouldn't, but basically there is a public disclosure of where there is and is not going to be a hospital. It's discussed. Could be conflict about it, but there's a public discussion about what to do. And I know I've studied France, and they certainly have that there. Because Friends has some rural areas that are depopulating, and they've had to have discussions about consolidating and closing some hospitals there. Anyway, so tell me about all the public meetings that happened before this hospital in Atlanta closed. Like, surely they must have had a lot of public discussion about what should be done with a hospital that was losing money. They didn't just close it and that got into the newspaper, did it? It can't be that way. I mean, do they really do that to the community?
Indeed, this was our biggest problem with it. I mean, what we all got, what City Hall got, what the mayor got was an announcement from Wellstar, not we're in trouble, we need help to stay open. Was, in fact, we've crunched our numbers and we're closing. And basically there was nothing anyone could do about it. They announced the closure. There was a huge outcry. There was an outcry from most of City Hall. There was an outcry from the community. There was an outcry from everyone at Grady, and the healthcare folks were against it. And it was a done deal. It was their decision and they were closing. And so what we ended up seeing was, sort of conversations about, well, what can Wellstar do to mitigate the loss here, to mitigate the harm here? Can they partner with the city, or can the city step in and now do something with that space to replace what's going to be lost? And in the end, it was just a lot of outcry and it, a really important organizing incident or event. But they ended up closing it. And after all the talk about what they might be able to do with the space, they're going to sell it to developers, and they're actually opening they announced later plans to open a new hospital in an Atlanta suburb, where understandably their reimbursement rates are going to be stronger because there's more people who are insured. So we didn't get a say. The community didn't get a say. No one got a say. This was a hospital company decision.
And the employees at the hospital and the residents and even the CMO of Atlanta Medical Center didn't have a say in any of this. Like, just a very quick aside, the CMO actually interviewed at Grady for a lower down position after this. And he was just so disgusted about everything that happened that he actually took 2 years off of working. So he like just went and did locums in an ER for a while because he just couldn't believe that institution would make this decision without any sort of public discourse. But that's unfortunately that's kind of the reality of it.
The physician might have been surprised by the decision, not to speak of they weren't consulted in advance. I mean, this seems shocking. How much time was there between the announcement and the actual closure?
I believe it was like September to late October. It wasn't very long. That's my recollection, Toby. Like, it couldn't have been more than 2 months, and it likely was less than that.
Yeah, I believe it fully closed November 1st.
November 1st it closed, yeah.
And it was definitely announced like beginning to middle of September. They had a like staged closing so that these patients weren't just like dropped out on the street or like delivered to other hospitals unannounced, but it was very sudden, and the other hospitals in the area had very little time to react.
Any of the interns have any questions? We haven't heard from you. And if we're not going to now, please feel free to interrupt us. And before we leave Atlanta, wasn't there a second hospital that closed too by the same company? Is that right?
Yeah, so prior to the closure of Atlanta Medical Center, which is right downtown in the city, there was a smaller Wellstar hospital on the south side of Atlanta. So I think it was called Southwest Medical Center or Southwest Regional or something like that, but it was a Wellstar. It used to also be owned by Tenet. Again, Tenet was the previous, hospital corporation that had bought up these 2 hospitals, and then they got acquired by Wellstar, and then Wellstar closed The one that, so when Wellstar closed the one on the south side, all of those patients are shunted to Atlanta Medical, among other hospitals, right? And so then that gets shut down too. So I can't remember exactly when, but it was within a couple of years, I think, before AMC closed, that the Southside Medical Center also had closed. Is that right, Toby?
Yes, I also don't remember the exact timeline, but it was maybe even like within a year or two.
And that hospital was definitely in a community. It was a Black community. It was a community that was poor. And that's the pattern that we see. We have rural hospital closures. And then when we have urban hospital closures, they are disproportionately in areas that serve predominantly Black or people of color, certainly people who are living below the poverty level or at or below and are not insured.
Yeah. May I assume the other one was also no community involvement, no involvement of the physicians and other healthcare workers, it just corporate decision.
I
Dumped on
wasn't plugged in at that time, but I remembered hearing about it in that same way.
Yeah. Okay. Lauren, go right ahead.
Yeah, thank you so much for talking. So I guess the hospital closed about 7 months ago, or more than 7 months ago now, from my understanding. So since then, have you seen any changes in like the general public attitudes towards either like bigger healthcare systems or towards like rebuilding more community center systems, or even attitudes towards moving towards Medicare for all?
Yeah, Lauren, great question. I'll go first, and then Belinda, if you want to add in anything. I do feel like the community was very united against the hospital closure. And there was a lot of petitioning of Atlanta City Council and our new mayor at the time to commit to the or oppose the redevelopment of the property and to ensure that medical care was going to be included in any future plans for that area. Now, unfortunately, the amount of medical services that are going to be included in redevelopment plans is like really very minimal, and it's kind of despicable. And to Belinda's point, like Atlanta Medical Center also in a lower income, predominantly Black neighborhood, and now all of a sudden the city is selling this land to the highest bidder, and that's just going to contribute to further displacement of the community and gentrification. So there was a lot wrong with how this played out. I don't think that unfortunately I don't think the Atlanta City Council or the mayor's office did enough either. Although, you know, I don't know that they had the finances to necessarily do more. They did put a moratorium on redevelopment while they tried to work out with somebody to put a new hospital in that place. Unfortunately, that never came to fruition. So I think the community feels abandoned. I don't know. I think your point is a great one, tying this all back to the for-profit healthcare system. I don't know that anybody, and I guess we would have been the people to make that case. I don't know that we made that case well enough for the community to really tie it all together. But I do think that is, one silver lining that could come out of a situation like that is that we can bring the case back to the case for single payer.
Okay. Any other questions? Oh, we got Natalia.
Yeah, I mean, I think Toby, you just started to talk about what I was going to ask a little bit. I was going to ask about if the city and or state have done anything to repair the damages and especially prevent it from happening again in the future. It sounds like on some level they haven't done much. Okay.
So they put
Yeah,
a Band-Aid. Yeah.
Yeah. Sorry, Toby.
I was just gonna say, the state gave Grady a decent chunk of money to absorb the extra patient load that they were going to anticipate. But it was a Band-Aid, right? They didn't do anything structurally to change the circumstances that led to this. And sorry, Belinda, I didn't mean to interrupt.
Oh, no, that's fine. I think we both had something to say about that, and we agree on that. I think that this, to me, one of the things that I think was most important about this is the visibility of rallying, and we've rallied at the site since then. We've actually used that site as a place to rally for, other causes in terms of healthcare equity and access, and publishing op-eds about this, really highlighting to the city and to our elected leaders, bringing this out of the shadows, that these are the impacts of structural racism, and we're watching them play out in real time. It is a structural problem, and you, like Toby said, a Band-Aid is not going to fix it. I mean, this directly also, again, we tied it right into the conversation about Medicaid expansion. How can City Hall reasonably try to court any hospital system to try to reopen a hospital in the city, in a place where you've got indigent folks, in a state that has an expanded Medicaid? Our leaders are crippling our attempts to support hospital systems and keep them from closing, and they're disproportionately doing that in areas that affect African American communities and poor communities. We did a lot of education around that, and I think that was really important. It didn't happen quietly. They did it very quickly and without notice and without discussion, and we made a lot of noise about it. So I think more people are aware of these issues.
Yeah. It's funny when you look at this kind of event, you could say, well, it's due to racism. And equally justifiably, you can say this is due to a completely dysfunctional healthcare system where even the existence of infrastructure in a poor community is dictated by money, which this community didn't seem to have enough of to keep this for-profit entity in the area. And it's just, multiple causes, all talking about a country that is badly in need of pretty major change. Anyway, do you guys want to make any questions more for Toby and Belinda? Any of the interns want to ask any more?
I
All
do
right.
have a general question that
Alrighty.
I could probably just Google after this, but if you guys know off the top of your head, do you know the ratio of for-profit versus nonprofit hospitals in Atlanta? If it's sways more towards one or the other, even?
That's a good question. I don't know the exact number. Most hospitals are not for profit. However, I don't know how much you guys have talked about this, but like not for profit doesn't mean no profit, right? It refers to their tax exempt status. So I think that you can have bad players that are not for profit and for profit. And I mistakenly said Wellstar is for profit. It's not. It isn't not for profit. For tax purposes, but clearly like they're making decisions based on their execs profit motives, right? But no, I don't, unfortunately, I don't know that number off the top of my head.
Thank you.
All right. Well, why don't we move on to Chicago? And I hope that we may take a break in the middle of Chicago. We'll see how the discussion goes. But anyway, thank you two so much. And I understand that you're both you have day jobs, and if you can't stay with for the remainder of the panel, thank you so much for joining us. It's really helpful. Thank you.
Thank you.
Thanks for having us. Good to meet everyone.
Thank you.
All right. All right. So I have a special affection in my heart for Chicago, because that's where I did my residency training at the county hospital. And while I was there, I was fortunate enough to make a friend who's joined us today. and that's Susan Rogers. And she was partly responsible for my education. She was, I think, a year or two ahead of me. I don't remember exactly.
You were ahead of me, Marv.
I don't know. You got into a teaching position. Anyway, not how I remember. Anyway, obviously, my memory's not what it was. Anyway, so I wanted to talk about healthcare in Chicago a little bit, and there was no better person than Susan. So even though I have located her bio, I'm not actually going to use it because I'd like to hear it from Susan herself. So my first, okay, so when I moved to Chicago, I had never lived in a big city before that. And it was, to me, a very different experience to live in such a large city. And, like most white people, I lived on the North Side. And I knew about this thing called the South Side and the West Side, that they existed, and they were, the demographics were completely different in two respects, at least. One was white people, for the most part, didn't live there and didn't even think of living there. Like, you didn't do that if you were white. And the other thing about it is that it's considerably poorer. And my understanding is it's fairly deindustrialized too. That there were tons and tons of jobs in Chicago during the 20th century that attracted Black people up from the racism and the lack of opportunity in the southern part of the country, and for jobs in Chicago. And then later, when jobs started to leave the country, especially in the last quarter of the 20th century, it had very harmful effects on the lives and the economy of the South Side of Chicago. But I'm going to stop talking and let Susan talk about her biography on the South Side of Chicago. Where exactly were you raised, and what is your experience with the economy and the life there? Who are the people? And how did you decide to bust out of it and pursue the career you did? If you could, anyway, start out with Chicago and your involvement there.
Oh, sure. Thanks. I like telling my story because I think it's reflective in a way of how Chicago is. Now, I grew up in a neighborhood, Hyde Park, which was one of the few integrated neighborhoods in Chicago. And it was right, bordering the University of Chicago. So there were a lot of professors and others associated with the college who lived in that area. And I grew up with a wide variety of friends, different races from different countries. And so my experience was a little different. And I remember when I first realized where I was when Dr. King, Martin Luther King, came to Chicago to march against the segregation in the public schools there in Chicago. And I had an older brother, a younger sister, and my mother took all the three of us downtown to march with Dr. King. And it was just exciting experience. There must have been, I don't know, 1 million people there, maybe even more, that were marching with him. And it really opened my eyes to what was going on in Chicago, because to me, my world was still small. I was young, I didn't drive around to places, and it was mostly based in Hyde Park. But when I realized what was really happening in Chicago, because where I lived, they were going to, I was in 7th grade, and the high school that I was supposed to go to was not going to be able to handle all the 8th graders who would be graduating the year that I did. There wouldn't be enough spots in the public schools in that area. So there was a lot of community action to try to get a new school built. And the superintendent of schools was totally against that. And so that's why Dr. King came to Chicago to help march for that and to help us get a school, which we actually finally did. But what that kind of showed me was how important it was to be involved. And I think that I don't want to say the activist gene, but I think that whole experience and being there with Dr. King just showed me that you have to do more than just sit at home and talk about things. You have to go out and do things. And that's what happened. And what actually happened was that we did get a new high school that was built for us. And we had, for the first 2 years though, we had, what do you call them? The trailers in parking lots. And that's where I took biology as a freshman. And it was actually that biology teacher, Miss Fitz, who made me decide that I wanted to go to medical school. She's the one that got me interested in that. And that's how, and then I took chemistry in the same trailer the next year as a sophomore. So that experience really made a difference with me. But what was happening in the city was that they did not want to build another school for Black children in this neighborhood. And it was the community that finally got that done. Now, along with this, that was when the Black Panthers were very active in Chicago. And I don't know how much you know about the Panthers, but they're looked at as this violent gang. And that's what they did. But when you look at what they did, and this is what I learned during this time, was that what they were about was to do good. And they're the ones that started getting sickle cell trait tested on children, because there were a lot of Black children here who had sickle cell disease. And so they were the ones who started all that. They were the ones who started breakfast for children before they went to school. Because as we take it for granted that everyone should know that kids need a breakfast before they go to school, but it wasn't common knowledge. And they're the ones who did that, who, raised funds so that kids could get breakfast before they went to school. And so there was a lot of positive things that were done by the Black Panthers who were based in that city. And actually, there's several who became active with PNHP in future years as time went on. And it was that experience that I think, turned on the light bulb for me about how activism was important. And it continued my interest in being involved in those things. And in the last 2 years of high school, we did have a real school with a basketball team and a football team. So it was like a real high school. But the impression and what I got from that whole journey, marching with Dr. King, understanding what the Black Panthers were about, and it wasn't just violence the way they are portrayed, but they're the ones that started the testing that kids needed, the lunches, so that you could be, you wouldn't be hungry, but you would have a full stomach and learn while you were in school. And all of that. So that experience is what turned me around. And I know that when I finished medical school, when I went to medical school, my goal was to train at Cook County Hospital because of the involvement that I had seen growing up and what the involvement of Cook County was. And actually, that's where I met Marvin. We both trained at County at the same time. But it was an educational process, and it made me realize that, you have to look at what you see, not what you hear. Because a lot of what you hear isn't all facts, but you have to believe what you see. And what was going on in Chicago was pretty awful. The schools were segregated, hospitals were segregated. It was, just a mess. And so I've carried that with me through all of I think most of my career. And I ended up training at Cook County, and I kept that sense of fairness, equity, all of that followed me. And that was part of my mission as I continued my medical career. And I look at the things I've done. I've worked at a VA. I've been the president of a FQHC for a while. So I've done a lot of different things, but they were all geared to not making a lot of money, as some people who go into medicine do, but to provide care to people who didn't necessarily have it, who could not take that care for granted, and meeting people and getting involved with people and organizations who carry that through. And even when I was trained at Cook County, that's when there were several people there who were some of the founders of PNHP. Dr. Quentin Young, who was the chair, one of the leaders of PNHP, his daughter went to school. I was in school with her daughter. We were the same age and went to the same public schools. But that sort of guided us, so that we kept on track and that we never lost sight of what the goal was and what we wanted to do. And it opened up opportunities that, you may not always know were there, but being involved with these organizations and people like that, you get to see what's out there. And the Black Panthers in Chicago, eventually the chief of police, who felt threatened by them because they wanted to change things, they unfortunately were killed by the chief of police. And it sort of slowed down the movement for a while, but it did come back and we did pick up things again. But it was an interesting journey, and I see that I have always kept focused on the underserved. And that was what I did. That was what I did with my career. And I don't regret. I am retired now, but I don't regret doing it at all. Doing my career in an underserved hospital. I was also on the faculty at Rush Medical School. So I was also able to, fulfill that educational need too. I was in charge of medical student programs there. So all the students that came to the county. So I had an interesting journey, and I think that there were a lot of different aspects to my journey. And so I just encourage you all to just keep your eyes open to what's going on in the schools you get involved with, in the communities you get involved with, because there's a lot that you can get involved with that may fill some of the spaces of things that you want to get involved with, and it'll broaden your vision, it'll broaden your eyes, and I think you'll have a more fulfilling career, not just in knowing evidence-based medicine, but of how to be a good doctor. There's more to being a good doctor than just knowing medicine.
Susan, I just want to say we're going to have a session next week talking about career choice, career paths. And I just want to say yours is an example of you chose to work in a place that met at least two criteria for you. One was that your training itself occurred in a place where you felt there was a great public need, and I can tell you there was, because I was there too. But in a facility that had the mission of serving that community, as opposed to making a profit or just being a workshop for the doctors or something. The mission was meeting community need. And the other thing about your story was that you wanted to train in a place where you would have nurturing for your public health and even political aspirations. There were other people who were an inspiration, not just Quentin Young for sure, but other people as well. And it was actually part of my motive was I knew I was going to be working 100 hours a week. So I wanted to do it in a place where I felt like I could have allies.
Yeah.
And to me at the time, that was important. But I want to, if you don't mind, I would like to, if the students don't have any questions right now, I do want to move out to talking about Chicago a little bit. So the Cook County Hospital is sort of in the middle of town for the most part, a little bit slightly to the south, but it's close to downtown. And it serves, but when we worked there, over 90% of our patients were Black. In fact, we had something called the white sign. If an ambulance brought a white patient, they were going to be a train wreck for sure. because white people didn't use that hospital. Which sort of goes along with what Susan is saying, that she wanted to serve the Black community. Anyway, but there are other hospitals. So Cook County is a safety net hospital. There are other hospitals serving this large community, the south side of Chicago. And I'm just wondering if you give a sense of how those hospitals are doing. Are they thriving? Have their closure have been issues with? I do think that and you can talk about primary care too. Our primary care service is readily available in most of the communities, as well as community hospitals. So go ahead.
Yeah, the patients that Cook County Hospital served was mostly patients who had Medicaid or had no funding, because nobody was ever turned away. And one of the things too that I really liked about it was that it was like a single payer system. Is that when you saw a patient, you know that they would get their medicine because the medicines were covered by going to county. You didn't have to come out of pocket to pay for your medicine. So you saw the doctor, you got your medicine before you went home, and then there wasn't any issue about how your blood pressure wouldn't be treated because you didn't have the medication. It was all part of the process, and the process was built to provide that, so that it was able to take care of patients in a lot of different ways to cover their needs if they didn't have an ability to get some of the things they'd done. Now, part of the problem though with county is that there were things there that unfortunately were not provided. And over the years working there, it became clear that there were a lot of older patients who needed joint replacements, who could not walk because of either their knees or their hips or something. But county couldn't pay for the hardware, even though Medicare would have, Medicaid would have, but it wouldn't pay for the hardware. So they ended up, having difficulties with mobility. So even a safety net hospital like county wasn't able to take care of everything. But I'll tell you, some of the conversations and the seeing patients in the room there was just phenomenal. Some of the stories that I got and how needy patients really were in a lot of ways. And I think that wanting to take the time to really get to know what patients needed, and some of the stories I had were just phenomenal. And they really made seeing those patients rewarding. It was such an experience to hear their stories and to take care of them. It was better than solving the medical problem. In a way, that was the easy part, but dealing with social issues was harder. And, to be part of the team that took care of those patients was rewarding in itself.
So again, going back to the south side, how is our services distributed on the south side? Are there enough hospitals? And I heard that Providence closed sometime recently. It was not a small hospital.
That what is closed?
Providence Hospital? Right?
Providence, yeah. Well, what happened was that Providence got bought by the county, and then it was taken over, and it really was not the same philosophy of just caring for whoever walked in the door as Cook County Hospital used to be. But I think that what happened was that the financing just sort of took over, and Providence, even though it was part of the Cook County Hospital system, it didn't have the same residency programs that Cook County Hospital had. So there weren't as many younger physicians and all of the other things that came with a teaching hospital that were at Providence. And I mean, I was born at Providence Hospital. Providence Hospital at the time was the only hospital that Black women who were pregnant could go to and deliver their babies unless they presented close to delivery at another hospital, and they couldn't turn them away. But most Black people my age who were born in Chicago were born at Provident Hospital. Provident now has been torn down. It doesn't exist anymore. And a lot of that is because of funding. But if we look at the hospitals that took care of patients who were uninsured, who did not necessarily have Medicaid or private insurance or Medicare, there's about 8 of those hospitals that took care of pregnant women no longer exist in Chicago. They no longer exist. And it becomes more difficult as a pregnant woman to have to go long distances to see a doctor who you are seeing often. Even if you have an uncomplicated pregnancy, it's a lot of visits and a lot of labs and things that you have to spend time doing. So those were, got lost with these hospital closures, and they left obstetrical deserts in the city. And they haven't been replaced. They have not been replaced yet. And a lot of that is that there isn't the funding to replace them. Then there's not the desire either to replace them. And a lot of it, happens through FQHCs, where I was the medical director for a while. And a lot of, especially younger women, would come through the medical center, and that's where they would get their obstetrical care. And we would also give them formula that was free, diapers that were free. So we were advocates, and we would help, these women and young girls who were pregnant. But there's been a large void that's been created by the for-profit healthcare system in Chicago by making it more and more difficult for other institutions and other ways to provide that care for women who needed it in the city there, because they're not funded and supported anymore. And it's more and more difficult. There's a hospital, Mercy Hospital, who actually, it's just 6 blocks from where I live now. It's just south of downtown. And they went, I don't know if they went broke, but they ended up being bought. It was a full service hospital, but it ended up being bought by three men, a couple of them who were just in their 30s. They were doing it because it was an investment opportunity. They bought the hospital closed after they bought it in a while. And it's not the same hospital anymore. Now what they mostly do, they don't do obstetrics anymore. They're not a full service hospital. They take care of more ER visits, and they often, transfer many of those patients out because they don't have the service to take care of it. But that's what happened to that institution. So it's created another desert in a Black community. And that's what's happening in a lot of cities. And I think there's about 7 hospitals that have closed in Chicago that used to do maternity care that they no longer can provide because they don't have the patients there who can financially support those institutions. It's
It
a
really
desert.
sounds like the community,
A desert.
the community health center program sounds like it's really important to try to
It's
fill in some of
vital.
those gaps.
It's
But I mean,
vital.
these are primary care only. They're not. Yeah. Any
Yeah.
questions from the interns before we take a break and move on to Philadelphia? Anyone have any questions? Chicago.
I think one comment I'd like to make is that one of the things that I think do show that community activism really works is there was a young man who was shot more on the South Side. I mean, he was like in his early 20s, was shot, was taken by an ambulance to a trauma center that was kind of far away, who died on the way to that hospital. And the reason he had to go there was because the University of Chicago closed their trauma center, and that man died. The community just rose up in anger. And I think it took about 3 years, but Now they have a full-fledged trauma center. They have a Black surgeon who came from the East Coast to take over that trauma center, and he still runs it now. And I think he's involved with the Lown Institute that does a lot of this advocacy stuff. And U of C has a phenomenal trauma center again, which they need based on the community that they live. But never underestimate the effect that you will have as an activist in making change. It happens. Me or Marvin wouldn't continue what we're doing if we didn't think that we were doing something that made changes that we thought needed to be made. It takes time, it takes work, but that's part of what my mission as a doctor was, not just to treat hypertension and diabetes, but to fix the system so that those things could be treated in a more efficient way.
And everything else.
Yes.
Thank you so
All
much,
that other
Susan. I
stuff.
really appreciate it. So we'll take a break until 3:55. And again, thank you so much.
Oh, thank you for asking me to join you.
What?
Yeah.
Can you hear me?
I can hear you.
Suddenly my
Yeah.
internet looks unstable.
I just got a message that mine was as well. So why don't we proceed while we can hear you and move ahead with our story. So so far we've heard about Atlanta and Chicago and developments there, and also how the personal story can fit into even the city you live in. So we'll now move to the epicenter of closing safety net hospitals. Sorry, Walter. Anyway, we'll turn to Philadelphia. And I'm really pleased to that Walter Tsou has joined us, maybe for the 5th or 6th year in a row, which we really appreciate. And before we start talking about the situation in Philadelphia's healthcare system, if you don't mind telling us a little bit about your professional career and how you started things out and what your hopes and goals were. So tell us about the beginnings of Walter Tsou as a physician.
Yeah. Well, can you hear me okay? Because I hope my
Yes.
internet's working okay. I went to medical school, I was like a typical pre-med, went right to medical school, and I didn't have a whole lot of, I think, personal development to figure it. I think people should probably take a year off or something and learn more about themselves. But anyway, I just went right to medical school, and then afterwards I decided I would do an internal medicine residency, and I matched in Philadelphia at one of the Penn affiliate hospitals, Presbyterian Hospital, where I did my residency, and it was kind of an eye-opening experience. And a lot of people came in with seizures, strokes, heart attacks, all things that turned out that potentially were preventable if people could take better care of themselves or prevent illnesses. Anyway, I figured I would do my practice in private practice in internal medicine, and I was sort of waiting for a doctor to put his arm around me and say, "Why don't you join my practice or something?" But turns out nobody did that. So one doctor said to me, "There's a health center up the street, and you can work there for a year maybe, and then you can join somebody's practice." So I said, well, I had no other better choice to do. I said, why not do it? So it turns out that the city of Philadelphia ran these city health centers, and I decided I would work at one of them. And it turned out that it was a much more pleasant experience than I thought. I mean, I was actually making more money than I did as a resident. It's not saying much, but I actually had patients who put their trust in me, and it wasn't like the people who were the frequent flyers at the ER. They were people who came back repeatedly, and saw me as their family doctor. They just happened to be very poor. And every day they would say to me something like, Dr. Tsou, if you weren't here, I don't know how I'd pay for my medicines or put food on my table and so on. So I think I learned something that I never learned really much about in medical school, which was something called public health. Now, the advantage that you guys have is that they teach public health now, at least to some extent. But I decided after I worked taking care of patients, I figured that public health really is my new career. So I decided to get a master's in public health because that's what people seemingly do if they want to go into public health. And then I decided that I would work. So I went to Hopkins, got an MPH, came back to Philadelphia, and I said, "Okay, I'm back. What do you want me to do?" And they wanted me to be a doctor again in the health centers, and I said, "Listen, I didn't spend a year of my life getting an MPH to do exactly the same thing that I was doing before." So I told them I only want to work on public health programs for the city. Now it turns out the city had not just one of these health centers, but 8 of these health centers, and together they served like 100,000 patients. So it was almost like its own little city of low-income patients. And if you think about it, there were a lot of grants at the time that were specifically trying to target low-income patients to try to get them access to different services. And what better group could do that than the city health centers? So I started writing grants, which was a novel thing for the city of Philadelphia. They didn't know they never had anybody who actually wrote grants for them. And, we started bringing in programs for the city. And I thought, this is turning out to be great. Well, I could go on, but the long and short of it is that just about the same time this was happening, there's a county outside of Philadelphia called Montgomery County, which I'm sure Natalia knows about. It's at the time the largest county in America without a health department. And my friend called me up and said, "Would you like to start a health department in Montgomery County?" And I said, "Well, I'm having fun in Philadelphia, but tell me more." Anyway, the long and short of it is that he said, "You get one chance like this in your whole life where you get to start something from scratch." And I thought about it and said, yeah, he's right. So I left to help start the Montgomery County Health Department, which is right outside of Philadelphia. And that turned out to be an amazing experience also because we really had a chance to start something from the very beginning. And then the position for health commissioner of Philadelphia came up. And I thought, well, why not go back to Philadelphia are you guys still there?
Yeah, you froze for a second.
I froze. Yeah, I think I disappeared. Anyway, I came back. They said, okay, you can be the health commissioner. So I think my experience of having worked in the city health centers, helping to do these grant programs, all helped actually my appointment to be the health commissioner. And then after I left the health department, I was elected to be president of the American Public Health Association, which is sort of represents a lot of the public health entities across the country. And then I had done just about all the public health jobs in Philadelphia. So I had a choice to make about whether I wanted to leave Philadelphia and do more public health, but I decided I'd rather stay home. And I had a young daughter at the time, and it was better for our family to just, stay in Philly. So anyway, that's the long and short of what I did, and now I've been basically advocating for public health stuff, which it turns out right now under this administration, advocating for public health is a worthy and laudable goal because it's definitely under attack. nationwide. I mean, the guy doesn't even believe in vaccines. He's getting rid of the CDC, the HRSA, on and on. I can go on, but we've never seen the type of decimation of public health like he's doing now. And because I am not beholden to, or I don't have to be politically correct anymore because I'm retired, I don't mind speaking out and denouncing what's going on out there. So I write op-eds and letters to the editor and talk to people about what's wrong with the healthcare system.
Walter, I have a question. So, Walter, can you hear me?
Yeah.
Okay. So around the time that you were towards the beginning, the first third of your career, there was a decision to close Philadelphia General Hospital, which was a large hospital, and I assume it was fairly critical to serving the poor people in Philadelphia. So do you know much about the circumstance of that hospital
Yeah, I
closure
do.
and what replaced it?
It happened in 1976. Philadelphia, if you can imagine this, back in the 40s or 50s, maybe, Philadelphia General Hospital and Mass General Hospital were like neck and neck as the most coveted residency program for medical students. I mean, it was really one of the premier places where if you really wanted to learn medicine and see a lot of pathology, you'd want to go to like MGH or PGH, Philadelphia General Hospital. And the medical schools in Philadelphia has several medical schools. So they all came in and they sort of divided up the hospital and created their own fiefdoms. And they all would bicker and fight with each other. And the city of Philadelphia was funding all of this through their tax dollars. And the mayor at the time was a guy named Frank Rizzo. And he said, this is ridiculous. This costs us a fortune to have a run a public hospital. We're getting out of this business. So he basically announced in 76, they closed the Philadelphia General Hospital, which was one of the premier hospitals in this country. And there were huge protests about this. And the whole discussions about what are we going to do for the poor who need health care. Well, one of the things they did was they made an investment in ambulatory care, primary care clinics. So that turned out to be when I was working in one of these primary care clinics. That was one of the investments they made. Now, not surprisingly, over time, they started whittling down money for the health centers too, to the point now where they're sort of hanging in there. But there was a promise at the time that they would run these city health centers. And the deal was if you needed hospital care, those 5 different medical schools and hospital systems that were out there, they would have to agree to be responsible for taking care of the poor. So lots of people in Philadelphia had to get their medical care split up, not at Philadelphia General Hospital anymore, but at one of this hospitals like Penn, Jefferson, Temple, Hahnemann, and so on. And that's what happened to PGH. And right now, what's sitting on PGH property is this enormous complex that the University of Pennsylvania, the Penn Medical School, has put together, and Children's Hospital of Philadelphia. It's a pretty world-class center. It's kind of like Baylor or something in Texas. It's this big sprawling campus that used to be where PGH is. So they still use it for medical purposes, if you will. Well, listen, let me ask you, can I share, can you let me share my screen or something?
Sure, go right ahead.
Are you going to ask me something more?
Yeah, just how whether the universities were willing to treat those patients and whether it sounds like the community health centers picked up some of the primary care part of it, and they probably were just to different hospitals. needed hospital care.
Somehow or other, the sharing screen didn't work. Is that,
I mean, at
am
the
I a
time of
host
that
or something?
hospital,
Well, not surprisingly, the distribution of taking care of the poor was proportional to the poverty areas of the city. So it turns out that Temple, even to this day, which is in North Philadelphia, and parts of West Philadelphia, had a disproportionate number of the poor people. And so even though they agreed to take care of the poor, more of it ended up at Temple, and there was a hospital called Misericordia Hospital in West Philadelphia that eventually closed. They were taking care of a lot of the poor.
and the community health center program was only 5 or 6 years old at the time that that hospital closed, but there were enough already. Is that the idea?
Yeah, this city, like a lot of cities, had these well baby clinics, and they converted the well baby clinics where they would, weigh babies and give them the immunizations, to more of a primary care center, which is rather innovative for most health departments. In fact, if you go around to this day,
Right.
most health departments do not do primary care. But that's one of the things that was nice about Philadelphia, that they actually had a primary care program.
All right. So fast forward to today, we have what you're left with from that are
Well,
we're definitely having internet trouble with Walter.
I don't know what it is with me. All of a sudden, it was perfectly fine until
Walter, give one more try to share
maybe
your
what I
screen.
should do is, okay, let me see if I can share. How do I share the screen? It says here. Share sound, layout's an option.
Yeah, and just click on whatever you're wanting to share.
Open, can you see this? Let's open systems.
Not yet.
No. Oh, it's a shame because I was going to show you my slides, but somehow, oh, here, this might be it.
I think this is going to work this time.
Can you see that at all?
There you go.
Can you see anything?
Yeah.
Oh, you can. Oh, good.
Yes.
Oh, finally.
Yep.
Okay, let's see if this works. Can you see that still?
Yeah.
Okay, so I'm going to talk
Yes.
a little bit about some of these hospital closures. And but before I do, I want to start off with this slide from Atlanta Medical Center, because it turns out that I was at that demonstration that Toby was talking about. Too bad Belinda's not here anymore. And I think that's him right there. He was protesting, and PNHP was there at the protest in front of the Atlanta Medical Center 2 years ago. All right, here's Philadelphia. Philadelphia has these academic medical centers. The big ones are like Penn, Temple, Jefferson, and Hahnemann. And Hahnemann, you see, is actually right in the middle of these three other big centers. So in many ways, it's kind of like centrally located. And what's the point of that? The point is that when a city, Hahnemann is like 150 years old. And when a city gives away its real estate for a hospital, It picks the very best properties, the best real estate in the city. It tries to give its most centrally located real estate. And that's what Hahnemann was. It was sitting right on a subway stop and a major intersection in the city of Philadelphia, and it's still there. The other center I'm going to talk about is Chester Crozier Hospital. And Philadelphia and Wilmington over here in Delaware, it's about, I don't know, 40-minute drive. But in the middle here is this city of Chester. It's a very poor city, in part because the largest incinerator in Philadelphia, in the East Coast, is in Chester. And nobody wants to live in Chester. Only the poor people end up living in Chester. So anyway, that's like the major medical center. If you can't get to Philadelphia or Wilmington, it's Chester. And there's probably like 1 million people who live in this area, if you look at the suburbs in South Jersey and so on. So it's not an insignificant number of people who were, served by the Crozier Chester Hospital. I want to start with Hahnemann. Hahnemann was a nonprofit hospital. It's over 150 years old. It ran into financial problems because of very bad case mix, I guess, and all the prestige people money people wanted to go to Jefferson or Penn. So anyway, it was ended up being bought by a for-profit group called Tenet Health Systems, who later sold it several years later to Paladin Healthcare Capital, who later sold it again to this group called Midcap Financial, Apollo Capital Management, and a real estate company, Harrison Street Real Estate, which I believe is in Chicago, of all places. And what does a real estate company want to run a hospital? Well, not surprisingly, a year after they bought the place, the whole place goes bankrupt. This is, a hospital that had like, I don't know, 500 or 600 beds. It's a very big hospital. It's a major teaching hospital for Drexel Medical School, as Natalia knows. And in bankruptcy, they argued that the real estate should be held separate from the bankruptcy proceedings. So basically, everything about the hospital should be allowed to go into bankruptcy, but the buildings themselves. Later, it turns out that the judge said you can't do that, which is why the hospital still has not turned into a condo. But look at where Hahnemann is. Hahnemann sits where really within eyeshot of City Hall and the Pennsylvania Convention Center here. And when Hahnemann was going to be closed, there were huge protests trying to defend Hahnemann. And you can think about whether this could be a great condo or hotel, which is what I think the real estate investors wanted. And when they decided they were not going to allow it to be part of the bankruptcy proceedings, guess what? This building is empty. This is now like 5-6 years later, and it's still empty, and it's just sitting there in the middle of Philadelphia, unused. But the protests were very big in the city. And, people wanted to keep Hahnemann open, patients before profits. And it was very clear that, people wanted to save the hospital. They went speeches in front of City Hall. And not surprisingly, one of the themes was Medicare for all. Because had we had a Medicare for all system, Hahnemann would still be here today. So sadly, in 2019, that's 6 years ago, Hahnemann closed. And when Hahnemann closed, this was never in the newspapers, but I took a picture of what Hahnemann looked like. The people at Hahnemann got up to their windows and put in the windows pictures of what used to be in each of the parts of the hospital. So here's medicine. Here was, there was like labor and delivery, patient transport, pharmacy, so on. So the point here is that people were very proud of working at Hahnemann, but they no longer had a place to work anymore. So why did this happen? Well, the case mix turned out to be not good. It was very much dependent on Medicare and Medicaid, and there was a lot of uninsured people who came to Hahnemann, and people who had private insurance, a lot of them wanted to go to the name hospitals like Jefferson and Penn. And they were able to negotiate better commercial rates from the Blues and so on. It's a hospital that started in 1848, emerged with the first women's medical college because women could not go to medical school. And so Medical College of Pennsylvania, which was founded in 1850 and only let women in there and were taught and was a very proud tradition of women's medical college. That became Medical College of Pennsylvania, which later on merged with Hahnemann to form Drexel Medical School. So that is the provenance, if you will, Natalia, of your school. And it was an academic medical center. And Hahnemann was the major hospital for Drexel. So what happens? Drexel goes bankrupt. 560 residents suddenly become unemployed. And not only do they become unemployed, but they find out that they did not have the right malpractice insurance. They had something called claims-made insurance, not occurrence insurance. What does that mean? It means that your insurance covers you for the time that you're employed at Hahnemann. And once you leave the mothership, if you get a lawsuit after you leave, you're in trouble because Hahnemann will no longer, Hahnemann will never cover, malpractice doesn't cover you anymore. You're on your own, you're hooked. So this was a disaster for all the residents, which I can guarantee you as medical students, nobody ever talks about thinking about what this might mean for you if you do your residency. Not only that, but for Drexel, like 1,100 students are at Drexel Medical School. It's an enormous school. And they suddenly lost their major teaching hospital. So Drexel today has gone to all kinds of other places, including even as far as California, to have their clinical rotations for the students. But one of the places that they rotated to was, ironically enough, Crozer-Chester Hospital, which I showed you earlier on the map, sits between Wilmington and Philadelphia. And the thing that I think you should take a lesson out of this as medical students, because you never think about when you match what it might mean. Figure out who owns your hospital that you want to match to. See if it's owned by a private equity firm. And because the implications are going to be very important. What does it mean for the neighboring hospitals? Well, my friend Ted Christopher was head of the ER at Jefferson, and he told me that their patient visits went from 200 to 300. That every day 35 patients will wait outside in the ER, hoping that a bed would open up. And the staff was totally burnt out at Jefferson. And now with Crozer-Chester closing, it's actually gotten worse. In the middle of the pandemic, the COVID pandemic, there was this empty Hahnemann Hospital. And you would think that some altruism would be out there with these entrepreneurs and allow COVID patients who needed to be hospitalized to be in the Hahnemann Hospital. But no, they wanted $1 million a month for them to board people at Hahnemann. And the city said, we're not doing that. So much for altruism. The private equity formula works something like this. You bail out the hospital, you take out the hospital, you sell out all its major assets, but you sell the prime real estate that was given to them 150 years ago, the best real estate in the city. You sell that real estate to some for-profit equity company. You let the hospital close, and then you charge the hospital rent to stay on their own property at exorbitant rates. So the goal is not about patient care. The goal is how much profit you make. I mentioned Crozer-Chester Hospital. This is the more recent one. This literally happened in this year. It was bought by a group called Prospect Medical Holdings, who decided that they were going to do the same private equity formula. This is a guy named Leonard Green and his associates, his shareholders. The hospital sold underneath them to a group called Medical Properties Trust. Remember that name, Medical Properties Trust, for $420 million. The The hospital, after selling off all its assets, paid its shareholders $457 million that they get to keep. The hospital is unable to pay the $35 million rent, forcing it into bankruptcy. So Crozier Chester now goes bankrupt. So in the closure of Delco Hospital's Crozier Chester, there's a real warning sign about what the implications are for private equity ownership. And I want to, before I go on, I want you to mention that Marvin gave you a link to this YouTube video. It's 25 minutes. It's worth your time to spend 25 minutes on watching it because it has implications to how you should pick your residency program and the match. And one of the things you'll learn in listening to this video is who actually owns the money that pays your salary as a resident. And if you don't know the answer to that question, you need to watch this video because the implications for your residency and for every medical student out there who wants to apply for residency needs to watch this video because it has huge implications to what your future will be in this situation. For Crozier Chester Hospital, all the people who were in that hospital, all the 520 people at Hahnemann Hospital, all the residents were now suddenly without a program. And they had to scramble to find a new surgery residency or medicine residency or family practice residency and hope that somebody would take them. And there's no guarantee out there they won't be left in the dark. So the implications are and still remain profound for people at Crozier Chester. This formula
Walter,
was repeated
sounds
also
like
in
also
New England at Stewart
the
Health
community
Centers, which the real estate was owned by Medical Properties Trust. And they also ended up selling the property underneath these hospitals, and they went bankrupt. So in the end, in conclusion, the real question is whether healthcare that we practice is a public good or it's a market commodity. I know we talked earlier about Atlanta Hospital. I mean, the truth is that if you think about healthcare as a market commodity, then if you happen to have the misfortune of being in an area where the case mix is poor and a lot of poverty in your area, you're not going to make it as a hospital. But if you're a private equity firm, you're perfect because you're going to declare you're a perfect entity where you can sell off the assets, sell off the real estate. You've gotten the best real estate in your community and it's worth a lot of money and you will make a lot of money out of that. But if healthcare is a public good, all those bets are off because how we think about our hospitals as a public good is a very different philosophical issue than if it's a market commodity. Okay, I'll stop. I think you're at 4:30, so I should stop. You can probably close the talk. That's my talk. I want you to think about, what it means for the different hospitals that you might apply to in the future when you do your internship and residency.
Yeah, Walter, why don't you unshare your screen and we'll have time for a few questions. And I just wanted to point out that these closures affect the community and they affect the employees and also teaching programs as well as economy of the city. So I imagine Chester, Pennsylvania, where Crozier Hospital is sitting, which you already said is a poor town. Now it doesn't have a hospital. All the employees will have to figure out what to do.
Yeah,
Many of them
I
will
didn't
leave the
mention
area.
that.
So
3,000
do you know
healthcare
if there's
professionals,
facilities?
3,000 lost their job overnight. That's a lot of people, including many doctors. It had the number.
Were there any public discussion
There was
before
a
it
lot of
happened?
public discussion. And actually, Prospect strung it out. They said, listen, we're going to close in next week unless you give us $20 million to stay open because we have to pay the salaries. So what? The county came up with some money, the state came up with some money. The next 2 weeks came by, they said, we want another $20 million to stay open. Finally, the state said, that's it. We can't keep doing this. So they closed, so Prospect went ahead and they closed it. All of it's perfectly legal because the healthcare, if private equity can own hospitals and do whatever they want to it. And that's the world we live in today, unfortunately.
Any other questions? Walter, has the government in Pennsylvania thought about whether to ban private equity ownership of health facilities after these events?
Actually, he has. The governor, after this terrible experience, has said, we really need to do something about private equity. But they're in the midst of a budget deficit right now, as many states are. And it's consumed all their time, and they haven't really had a chance to really think about what they want to do about how to prevent private equity from doing this again. They have publicly stated that they want to pass a bill that requires any private equity entity buying a hospital to have it approved by the Attorney General. And in Pennsylvania, the Attorney General is a Republican who's a strong Trump supporter. So it's very likely that he is not much of a backstop to prevent private equity from taking over a hospital.
Natalia, did you have a question? I'm sorry if this talk hits close to home.
No worries. No, it's always good to understand more. I actually kind of had a leftover question, so maybe if someone has a question like that's very relevant to the conversation right now, they should go before me. But if not, my question was for Dr. Rogers and Dr. Tsou as well. But it had to do with something that Dr. Rogers brought up earlier about how there was a Black physician who came, I think you were saying, back to University of Chicago to establish the trauma surgery department again. And so it had me thinking about how a lot of the time this conversation centers around primary care, and primary care physicians are often the most involved in this movement. But how can specialists be active in our current healthcare system as it exists to try and kind of change things and be part of the movement?
Well, if you want me to answer that, because you mentioned my name, but I think that one of the things about, specialists and all, they do different things even within the same specialty. And I think a trauma surgeon is kind of unique because they don't have their own practice. They see patients as they come in. And so the whole crux of their specialty is for the community or whoever gets brought there by ambulance as a trauma patient. And I think that, a trauma surgeon is a little bit more unique because he's not trying to build his practice, like other specialties will do. But especially in a neighborhood, if you look at the neighborhood of the University of Chicago, it's a poor neighborhood. It's a very poor neighborhood. And they often don't take patients necessarily on Medicaid for routine things. I mean, I'm not really sure how they function there, but the thing about a trauma surgeon is that it benefits the community. And that was the whole argument that community was making when they wanted this trauma surgeon, this trauma unit to be there, because clearly a young man died who lived in that community because it wasn't there. So, I think it meets the need, and that, it's unfortunate that hospitals are still driven by profit. I mean, they're private entities and that's what they want to do. And that's also how they can build. But they've done it pretty well. I mean, I know the guy who's in charge of the trauma unit there, and he's got his goals are consistent with what the community needs.
I'd like to take a stab at your question, Natalia, a little bit. The causality may be more complex in the sense that when you're working in a community health center, you're seeing a lot of people with unmet needs and with diseases they wouldn't have if they were wealthy. And it may then affect your future attitudes, political attitudes, and your attitude toward getting involved. Whereas a lot of specialists, they're busy and they're, working on fractures if they're an orthopedist or whatever. And so they just kind of do, in their own specialty world. And so that may have, so who is one thing, and then the somewhat narrower scope of their work come in more of. Now, having said all that, the opposite can be quite true. You can have surgeons. Next week, you'll meet with a chief medical officer at Cook County Hospital, and she'll tell you that the specialists who've chosen to work at that large safety net hospital Susan was talking about earlier, that they're critical to the hospital functioning, and she just loves it when, as the chief medical officer, when a specialist wants to there. And I think it's great if some of you choose a specialty. There's many advantages for a specialist and a PNHP to have you. So it's not yet the orientation of people who chose primary care started out maybe being, more community oriented and brushing yourself. If you want to go into, become a surgeon, do it. You can still be involved and try to make the world a better place. So anyway, so go ahead, Zach.
Just building on the specialist discussion, I don't know if we've gotten into this, but specialists drive a lot of the revenue for hospitals. So I think in terms of like labor, they also have probably the biggest say in directing hospitals and putting pressure on healthcare administrators. Because if you're the cardiologist running the cath lab and you're like, we need to treat our community better, then you have a bit more say than the primary care provider who's like a loss leader, and like there's not as much financial incentive to listen to you. So I've also wrestled with the idea of maybe being a specialist, you have more of an impact on helping your community. So I'd be interested to hear what people have to say about that.
When you read the book, The Hospital,
Well,
you saw some of that. Go ahead.
I think you should do what your heart tells you want to do. I mean, you'll do your rotations and then you'll figure out what really, captures your heart. I thought I was going to be an orthopedic surgeon when I started medical school, so you just never know what's going to happen. And I ended up working in public health and internal medicine. And that would not have happened had I not just gone through my clinical rotations. And when I decided that waking up at 6 a.m. to do surgical rounds was not my cup of tea, that's when I knew I was not going to do orthopedics. And but each person's very different.
I will
Yeah.
say too that I think that a lot of what you do, if you're a specialist and all that, depends upon your employment arrangements, because if you work for a group, you may have to do what the group says. And if you have to do so many procedures or see so many patients, that's what you're obligated to do. Versus maybe working at a safety net hospital, and I use the example of Stroger Hospital, Cook County, is that you're not making more money by seeing more patients because you're salaried. So you have a little bit more flexibility of what you may want to do and not do. You're not going to be driven by just generating more money that you may be in that position in a private setting or in an institution that wants to bring in more revenue versus do more procedures or help more people.
Yeah, so that's sort of the same, reflects what Walter said earlier, that you want to know who owns your hospital. Orientation
Yeah.
is, want to know who owns the practice you work in, if you, and what
Exactly.
their orientation is, what could happen. Any more questions from the interns? No. All right, well,
Can I just make one comment? This
sure.
is just a reflection on what I had done in my career, is that if you don't like where you are, you have a skill and you can always move jobs. You can't necessarily move to another city. But I'm just saying that as physicians, we have some flexibility. And that you shouldn't feel like you're going to get stuck if philosophically where you are doesn't match with you.
Yeah.
I've had a lot of different jobs and it's okay.
All right, so thank you all so much. Walter and Susan, thank you so much for joining us. I really appreciate it. Thank you.
My
You're
pleasure.
welcome.
Yeah, and I'll see you
Bye.
guys
Good luck,
tomorrow.
everybody.
Thank you.
Yeah.
Take care.